the adrenals and the pituitary, it's surgery almost all the time. Not in every case, but a lot of the time, it's surgery is going to be the treatment of choice, right? From what you've heard to this point. So drug therapy usually is coming in secondary. So drug therapy is usually going to be used if you've got a person who's not a surgical candidate, or a person who refuses surgery, or once you've done surgery, there is still functioning tissue, and you're going to suppress it now through drugs. In some cases, they'll do a second surgery, but not always. So that's usually where drugs are coming in. So if you look under indications for medical treatment, surgery, contraindicated, you're getting them ready for surgery, so maybe you want to get the gland to shut down or decrease or stop putting out so much cortisol, or you may do it after surgery like we talked about. You got some residual tissue producing cortisol, or while you're waiting for the effect of a pituitary radiation. So that's where these are going to come in. Our goal is to normalize cortisol levels and eliminate the signs and symptoms that have been related to the Cushing's. So there's two strategies. One is called a block and replace, and the other is normalization. So block and replace means we knock out, we either destroy the cells that are causing the trouble, or we mitigate them in some way, and then we replace the person's glucocorticoids. Okay, so that's one approach. Normalizations means we're using a drug that will decrease the amount of cortisol that's being produced. Okay, so those are the two strategies. The way we will determine if we're successful is we can measure cortisol or we can measure urinary free cortisol. Did Professor Bean talk about that today? Okay. So I have never seen a patient treated for Cushing's outside of an endocrine group. They are really difficult to manage, but I think where you're more likely to come across them is in primary care or in specialties where you're addressing all the other problems. So it's good to know the drugs that they're being used to treat their Cushing's, because they can cause significant problems. But where you're going to run into a lot of the care of a patient who has Cushing's is under E. So let's look at those. It takes a lot of education, family and the patient, about what the disease is, how it's treated. Particularly some of these drugs put them at high risk for some life-threatening problems. So they have to know how to recognize them and treat them. But the cortisol-dependent comorbidities is probably where you will come into your care quite a bit. So the psychiatric disorders, cortisol levels, if they are high or remain too high, or if they get too low, you can see depression to psychosis. So a wide range. And at least the Cushing's patients I have seen there's a high level of depression. It is a difficult disease. It's just so tough for them to deal with. They almost always have diabetes. So the care of that, they almost always have high blood pressure. They have difficult to control potassium levels, so the monitoring of that. They are predisposed to infections because of the treatment that they get, but also because of the diabetes. And dyslipidemias go along with the triad of the other things you've seen, the diabetes and hypertension. They usually have osteoporosis because of the high levels of cortisol, effect on bones, and poor physical fitness. Because of the body habitus change, high cortisol levels also give you muscle weakness. They're usually obese, and so it's hard for them to move around. It is a very tough disease. So they really do need care by a multidisciplinary team. So lots of people need to be involved in the care, and I think a behavioral support person or a cognitive behavioral therapist is also a very good person to have as part of their care. One thing, and I put it in red, unless you're looking at it online, you probably don't notice it, but they are high risk for VTE. So they put out a lot of procoagulant factors. and they have an impaired ability to break down clots. So you must evaluate them for their VTE risk. They're about 10 times a normal person's risk for VTE, so it's very common. If they're going to have surgery, if they would need to be evaluated and prophylaxed as well, so keep those in mind. Offer age-appropriate vaccinations, so influenza we would want in everybody. The Pneumovax, the Prevnar I think would probably come in here as well. Herpes zoster, so all those things that would keep them particularly from getting infections that could be life-threatening, and then the herpes zoster, which is just such another miserable condition to have. Questions about those or comments? Okay, look at the next page, a couple of pictures. So I drew out some hormone pathways, and I picked this one out to kind of show you where the different zones are and where the different enzymatic steps and processes are taking place. So at the top, everything starts with cholesterol, everything. And then it's through different enzyme pathways that you get to the three endpoints, which is your cortisol, your aldosterone, and your testosterone. One thing I think that is good to note here is that you can see where if you suppress one process or stimulate one process, you can get effects in other areas. So if you suppress cortisol, then ACTH may then drive other pathways. So you may get increase in androgenic effects or effects from aldosterone on potassium. So sometimes it doesn't make sense. You're going, okay, this drug knocks out this. Why am I getting this result? So it's usually because of you're shunting fodder through different enzyme pathways. The other thing that I think makes it a little harder is that receptor sensitivity. So we'll see this with some of the drugs that at low levels of the drug you may get glucocorticoid receptors are affected. And the higher you go, then you get androgenic or mineralocorticoid receptors. So a lot of it is level dependent, and that sometimes I think makes it hard to figure out, okay, why am I getting this effect or this side effect for this person? And a lot of it has to do with just levels and sensitivity of different receptors to different concentrations of either the drug or the substrates that are there in the vicinity. Okay, so with that, let's go on to page 4. So there are 4 categories of drugs that you can use in Cushing patients, and they're divided as listed there. So there are steroidogenesis inhibitors, an easier word might be an adrenal enzyme inhibitors. So they will inhibit different points in the pathway of the production of cortisol. You can have androlytic agents, which are really chemo agents for adrenal carcinoma that just wipe out different layers of the adrenal cortex. Glucocorticoid receptor antagonists, or they're also called cortisol receptor blockers, are useful. And then all 3 of those work on the adrenal glands. The last one, somatostatin, works on the pituitary. It's the only one that we have that works there. So let's kind of walk through these. For the adrenal enzyme inhibitors, there are 3 drugs in this area. There are only 2 that are used on an outpatient basis, which is ketoconazole and metarapone. Ketoconazole is the drug of choice in this category. It's an antifungal drug. It's what we use to treat people's hypertrophic or fungal nails, and that's pretty much its major use. But at very high levels, it will shut down adrenal production of cortisol. And it does it at multiple places. I pointed out at least 2 on the picture on the page before. And that's what makes ketoconazole such a more powerful drug in the treatment of this disease, because it has multiple. So I showed you 2, but it also has effects up here at the cholesterol level in terms of the the first step in converting cholesterol to pregnenolone. It also affects there. So that's what makes ketoconazole powerful, much more so than what we'll see out of metarapone, which only affects one of the enzymatic steps. So lots of adverse effects at that level. Let me go back up. Under mechanism of action, this drug, or the drugs in this category, plus the androlytic drugs, are considered to be medical adrenalectomies. So they wipe out the adrenal. They can wipe out the entire adrenal cortex, or they can wipe out certain layers. So instead of a surgical adrenalectomy, which is what we would do under surgery, these are medical adrenalectomies. If you look under major adverse effects, it's important to know liver toxicity is big with this drug. It's a problem when we use it in the doses that we treat fungal infections. But using it in these levels is very high incidence, and it can be fatal. So monitoring people who you place on this drug, being very attentive to drug interactions. This is a very potent 3A4 inhibitor, so it's very important to always look up, when you use this drug, look up the interactions. There are many. So if you're adding a drug to a regimen that contains ketoconazole, or if you're adding ketoconazole to a regimen, always look up for drug interactions. That goes with all the azoles. They're very high in the number of drug interactions that they cause. So keep that one in mind. Following ALT, or that's the transaminase they choose, is the most sensitive to this drug's effect on the liver. If you get 3 times the upper limits of normal, then they recommend taking them off the drug. That's pretty classic definition of liver toxicity, is when you get 3 times the upper limit of normal. So if it's 5 to 40 and you get above 120, you would take them off the drug. A lot of times people will have transients, so if you do it very early in treatment, you may see it and it may go back down. But if it stays sustained, then that's the time to take them off. Drug interactions, one of note is that this drug needs an acidic environment to be, as part of its metabolism, to an active form. So if you use it with drugs that decrease acid or acidity in the stomach, you'll decrease the effectiveness of the drug. So don't use them with H2 blockers like ranitidine or famotidine, or the proton pump inhibitors like omeprazole. Lastly, the cardiac contraindications is that this drug is a prolonged QT interval. So be careful in using it, particularly with drugs that also cause QTc elongation. You can develop torsades with this drug in combination with others. And a lot of them would be using it with the antiarrhythmic, the 3A, class 3A, would be a high-risk situation. Questions about ketoconazole? The FDA came out in the last few years and said, don't use them. Don't use it like this. But they continue to use it because it's a very, very effective drug, particularly for folks who can't have surgery. So it's still used, but just needs to be highly monitored. Metarapone is another one in this category. It's very specific. It only inhibits the enzyme in the last step in the production of cortisol, so it's not quite as effective as ketoconazole. But you can, if you can get the person under control with ketoconazole, you can then transition them to metarapone. So it is an agent that could follow, or you can use them in combination if you have real refractory cases, since they kind of work in different areas. But that's mostly for men, because this drug has a high incidence of androgenic production. So it causes, invariably will cause hirsutism in women. So it's not recommended for use in women, but could be used in men. Because of it increases androgen production, salt retention, hypertension, aldosterone levels go up with this use of this drug, so hypertension can be a problem when using it. Okay, so that's that category. There is a third drug in this category, but it's only used IV and it's only used in the ICU, so I didn't include it. It'd be very unlikely that you'll run into it. Adrenalytics, so mitotane. Mitotane is a chemotherapy agent used for adrenal carcinomas. Again, it's used as a medical adrenalectomy, and it's used to treat adrenal carcinomas. So very powerful drug. It wipes out at least 2 of the layers. I put it up there, the fasciculata and the reticularis. So if you knock out the fasciculata, you must replace their steroid production. So you'd have to put them back on a glucocorticoid of some kind. Let's see, coming down. It has adverse effects that's a mile long, but I gave you the most common: nausea and vomiting, lethargy, and anorexia. If you have someone who is on this drug in a stress situation, the recommendation you see down there is to take them off of it and make sure that they are adequately replaced with hydrocortisone or a steroid because of their requirements will go up several-fold in a stress situation. They won't be able to produce cortisol to match that. So that would be a time where exogenous steroids would have to be used over and above what they're already replaced. Let's see. The fourth bullet down there, long-term administration with high doses can cause brain damage. So being careful about the long-term dosing levels, prolonged bleeding time. It is a teratogenic agent, so women who are on it need to be sure they're on adequate contraception. So that would have to be one with high efficacy. So you would think of something like an implantable steroid, progestin, sorry. Implantable progestin would probably be one of that you would want. Probably not so much the oral contraceptives because they rely on user technique. So something that is probably beyond what the person would have to do or manipulate would be a better choice. Okay, question about those?
I have a quick question. If
Yeah.
a drug isn't oh,
No,
no,
okay,
pass. If a drug is not FDA approved for a certain thing, do you have to tell your patient that before you can prescribe them it?
No.
Okay, I never thought about it.
When you are using an off-label, I think the biggest thing it comes into is if something untoward happens. Can you get up and defend what you have done?
Okay.
So the drug company cannot promote off-label, even if they're very common in use. They cannot do that. But in terms of somebody coming after you, they're not. But a drug company may, now insurance companies may say off-label use, we're going to deem it investigational, we're not going to pay for it. So I've seen that happen sometimes. But I think the only time you're going to get into trouble is legally if somebody can come and say it's not approved, you did this, there's no data behind it, then you'd be more at risk. Okay, glucocorticoid receptor antagonist. So this is mifepristone. This is a very powerful anti-progestational agent. It's an abortifacient. It's the RU486 drug. So it's more commonly used to induce an abortion, usually in the first 12 weeks of pregnancy. So that's its usual use. But it's very effective. If you look back through that on page 2 where I gave you the different pathways, you can see where at the very high level you can knock out many of the production, especially cortisol, with this drug alone. It has a particular indication in this sense is in that it will help control high blood sugars in people who have diabetes who also have Cushing's. It is never used outside of that to control blood sugar. So we never use it in diabetics to help control blood sugar. It's only in this situation because the diabetes, the hyperglycemia, is due to high productions of cortisol. In type 2 diabetes, so this would be like a secondary diabetes, a secondary cause. So in type 2 and type 1, it's due to the fact that they don't produce insulin in a way that will control blood sugar. So it's different causes, so we would never use this outside this, condition. Because of that you're affecting those enzymatic processes at a very high level, you also get disturbances in aldosterone. So they tend to have trouble maintaining serum potassium, so replacing is important. Adverse effects, fatigue, nausea, headache, fairly nonspecific. Endometrial hypertrophy, because you're using a progesterone and anti-progestin, then you can get changes in the endometrium, and that's pretty common. Black box warning is there for women in their reproductive years, a warning about the effects and the termination of pregnancies can occur with these drugs. And it outlines, when you should take it. Let's see. Pregnancy must be excluded before the initiation with this drug if treatment is interrupted for more than 14 days in a female of reproductive potential. Pregnancy must be prevented during treatment and for 1 month after stopping. This one also has lots of drug interactions, so looking it up, the statins, which these folks could very likely be on because dyslipidemias are pretty common, is a common interaction. And that's with simvastatin and lovastatin. Women with a history of unexplained vaginal bleeding, that needs to be figured out what is causing that before putting them on this drug, or with endometrial hyperplasia because of their risk for endometrial cancer. Okay, let's see. So going under the cautions, we talked about hyperglycemia unrelated to Cushing's. Adrenal insufficiency can occur, so you may need to administer glucocorticoids. So what would that adrenal insufficiency look like? What would people complain about?
Fatigue.
Fatigue is probably one of the big. Lassitude is another word used. It's just like, it's more than fatigue. It's like I'm not just tired, I just don't have the energy to do what I need to do. So those are probably two of the most common complaints. And then women, advising them about the potential for vaginal bleeding and to report unexpected vaginal bleeding would be important. If women are on anticoagulants, these are difficult, this would be a difficult drug to use because they could have very heavy bleeding, so you would probably take them off. You'd switch them to something else if you were going to have to use this drug. Or you'd have to switch them, you'd have to move to a different drug if they're on anticoagulants. Top of the next page, another QT prolongation. A lot of this QT prolongation comes about because of their effects on like potassium and magnesium. So where you're looking, it's like these drugs don't work the same. Well, underneath, they are affecting all those processes. So if you start to see, I'm seeing this with each one of them, it's because of the underlying problem on the electrolytes. So that makes it a little bit easier to learn these. Any question with these? The CY3A4 inhibitors are going to be a big trouble with any of these classes. Some of them, like this one, you can limit the dose. Some of them will be an absolute contraindication. You'd have to move on to a different drug. Okay, so those are the three that work on the adrenal gland. Now the last one is a somatostatin analog, and this is pasiratide. It's an interesting drug. It inhibits ACTH from the pituitary, so it decreases cortisol to even a higher level than when we were affecting enzymatic processes. It's indicated for adults who have Cushing's in whom pituitary surgery did not work or was not curative. Look at the baseline tests that are needed before starting the drug, and a lot of the reasons for that are underneath the cautions. So fasting plasma glucose, this drug tends to decrease insulin secretion, so a separate cause, but they tend to get hyperglycemic, so their A1Cs go up as well. Liver test, if you look on the next page, you can see that liver enzymes can rise and sometimes lead to a discontinuation. Getting a scan for their gallbladder because gallstone production goes up with these. An EKG, if you look on the next page, bradycardia and QTC prolongation again. Potassium and magnesium should be get a baseline. And you'll see other anterior pituitary hormones that also can be affected, so TSH and growth hormone and IGF-1. Again, lots of drug interactions. Some of these have, I would say, between 300 and 500 interactions. Probably in the range of 40 to 50 that are critical, and probably the majority that just require monitoring, but a significant number of absolute contraindications. Let's see. Okay. Questions? Unlikely, unless you're going to work for an endocrinologist, that you will prescribe these, but you may see them in patients. So the big thing I would always remember is I'd be thinking adrenal insufficiency. I'd be thinking steroid replacement. Are they on enough glucocorticoid? Do they need cortisol replacement? If you're seeing them like in an emergency room or a urgent care. Steroid replacement, on page 8, I've given you a chart. Yeah, and you in no way have to memorize it. What I wanted you to see is the complexity of a regimen to replace, I think this was post-surgery. So you don't have to know it, but I wanted you to kind of see what it would look like. So when they take out an adenoma, it's usually curative. But what happens is because if it's unilateral and you're taking out one side, one part of the adrenal cortex, the other gland, because that gland has been overproducing, the other gland atrophies. So it's not needed, so it just stops working, or it goes to a very low level. So if you remove out the active gland, then you can't produce enough, and that's why you're having to then replace for them. So replacement is needed for 6 to 12 months. The HPA axis can recover, but it is a very slow axis to recover. If you put someone on oral steroids for a period of time, longer than we've talked about in terms of those 2 and 3 week bursts, it takes the axis about twice as long as you had them on a steroid to recover. So it's a very slow process. So think long-term, and then on that last bullet, it gives you the endpoint. So assess adrenal axis recovery with an 8 a.m. cortisol. It's when your cortisol levels are at its highest. And the level should be greater than 20 micrograms per deciliter before you take them off. That tells you that the axis can now take over. Questions about that? Okay, that was a lot. Okay, so let's, on page 9, let's pick up hyperaldosteronism. So again, most of these are due to an adenoma, and so surgery can be curative. But if you can't treat them with surgery, then we need to address the problems then that come off of this. So how do we get to aldosterone? How do we get to aldosterone production? Oh gosh, you guys should be able to sing this in your sleep. So where's aldosterone come from? Adrenal cortex, which one? Glomerular. Oh, okay. So what produces aldosterone? How do we get there? Or what stimulates it, sorry. Say it again. Somebody just say it out loud. Loud.
Angiotensin 2.
Thank you. Where's that come from?
1.
What converted it?
Yes.
Okay. And then where did this one come from?
Renin.
And what converted that? Renin. Renal renin. Renin is a cow stomach. Okay? So renin, I can tell you attending just, I wasn't the person he reamed, but I never forgot it because he went all over the, I don't know if it was a medical student or what. So renal renin, renin, is cow. Okay? 2 minutes. All right, so now you've got hyperaldosteronism. So it's a negative feedback, so what happens up here, upstream, what happens?
Quits making it.
So renin is really low in these folks. Aldosterone output very high. It's given there for you. Blood pressure is high because what is aldosterone's effects? What does it do?
Sodium retention.
What's the target organ?
Kidney.
Collecting tubules, and what does it do? So it makes us reabsorb sodium, and what do we get rid of in exchange?
Potassium.
Potassium. Because we're trying to get water, trying to reabsorb water to increase vascular volume, right? Okay. So now you can kind of predict what's going to happen. Blood pressure, moderate to severe, resistant to medication. I read something I hadn't seen before. They estimate that this is more of a problem than we really pick up on, and that it's probably the cause of hypertension about 10% of folks. So that's high, higher than I would say that I've ever seen people looking for. But I have certainly run into these folks who are resistant, like 3 to 4 drugs, resistant to treatment. So hypokalemia, so you see where that comes from. Okay. And muscle weakness, fatigue, and headaches. The aldosterone to renin ratio, so that is a way we can measure this. So it's the A, so it's aldosterone to renin ratio, and it should be greater than 20 to 1. So as this goes up, this is just going to go down further. Okay? So 20 to 40 to 1 is a positive finding. So our overall treatment, what we want to do is we want to reverse the effects of that excess aldosterone. So the hypertension, the hypokalemia, the renal toxicity, the renal damage that can occur with long-standing high blood pressure and cardiovascular damage. So lots of things flow out of this disorder. So those are your goals of therapy: reversal of adverse cardiovascular effects, normalize their their potassium, normalize their blood pressure. So if it's unilateral disease, it's easy to fix usually with surgery. Bilateral disease is where you need a mineralocorticoid receptor antagonist. You can all breathe a sigh of relief because you have seen these drugs multiple times. They should be old friends. So you should go, oh gosh, I'm so glad, now I know something. So spironolactone that I don't have to pick up brand new. Don't you love it? So spironolactone and amiodarone, those two are aldosterone antagonists. The difference is their selectivity. So spironolactone's been around, I bet you 60 or 70 years. It's very inexpensive. Does have side effects that are sometimes not welcome. It has an active metabolite that's a canrenone. It has a very long half-life, like almost a 24-hour half-life, so it usually can be dosed once a day. But if you look over there, the number one, it's one of the number one causes of gynecomastia in men. If it's not breast cancer in men, drug-induced, this drug and Tagamet, very, very common. So keep that one in mind because it's one that you should have in your thoughts if you're seeing gynecomastia in men. Menstrual irregularities in women, hyperkalemia, you can see why. So you're going to monitor serum creatinine, potassium, and their blood pressure when they're on it. If you look at amiodarone, it is selective, so you get away from some of those side effects. So it doesn't have the androgenic side effects or progesterone side effects, or like you see with spironolactone. The big problem with it is drug interactions. So you'll note there that it's a 3A4 substrate. Otherwise, you're going to monitor similar endpoints. Amiluride is a potassium-sparing diuretic. Works on a different part of the tubule. It works more on the, like as you're coming off the loop of Henle and going up to the distal part, that's where a lot of this potassium-sparing diuretics work. So less effective because you moved it away from the site of action where most of this is taking place. So usually you're going to use it in combination with other drugs. So I would say it's probably a third choice if you can't use the other two. But potassium would be one of the big things to monitor. Questions about those? Okay. Well, the next section, the hypofunction of the adrenal gland, is fairly long. So let's go ahead and take our break now and come back at a little bit about 6 and we'll pick it up there.